Welcome to the Diverse Voices Speaker Series, an educational arm of Out on the Lakeshore's Pride Month programming. We had our first series last year, and we're excited to be back for a second. Pride is a celebration, and it's also a time for exploring, learning, and asking questions. That's what this series is all about. All of these programs are being recorded and are available online via Zoom for live streaming to make it as accessible as possible. And check us out at outonthelakeshore.org and on Instagram and Facebook to learn more about all of the fabulous events that we're going to be putting on for you this month. We wouldn't be able to make this programming happen without our community partners, including the Red Project, Bluestocking Bookshop, and of course, the Holland Museum. Thank you all so much for your continued partnership. So tonight, we're here to discuss an important piece of the LGBTQ+ community's story. Since its inception in the early 1980s, the AIDS crisis ravaged the queer community, changing the course of our history forever. Within this devastating history, there are stories of heroism and hope, love and resilience, compassion and pride. We wouldn't be here today without the folks who came before us, paving the way for a better future. So on a little personal note, my wife and I recently celebrated the birth of our son, Tate. He's 3 months old, and he's here with us today because of brave individuals who fought for access to things like medical research and care, marriage equality, and parental rights. My wife and I and many LGBTQ+ families like us are able to create a home and a family together because of these folks. I'm desperately sad that many of those individuals who paved the way are no longer here with us due to the devastating effects of this virus, made worse, of course, by the callous lack of action from those in power. But I am also incredibly grateful for the LGBTQ+ and allied individuals who fought for the care, acceptance, and life that we deserve. So the folks sitting on this panel tonight all have lived experiences with the HIV/AIDS crisis. They have uplifted our community, and they continue to do so tonight. We are so grateful that you're here with us to tell this story. Thank you. We've come a long way, and we still have a ways to go, but this is a community that doesn't give up. We will continue to create a better future for those who come next. And best, and maybe most importantly of all, we will continue to celebrate this community together. I celebrate all of you here tonight. Thank you for coming and learning with us. And with that, I'll hand it over to Olivia from the Red Project, who's going to give us a little info and also as our host for the panelists this evening. Thank you.
Hello. This mic is working. Y'all can hear me? Gorgeous. Hello, I am Olivia. I am with the Grand Rapids Red Project. For those of you who haven't heard of the Grand Rapids Red Project, we are a 501c3 nonprofit located out of Grand Rapids. We are, at our core, a harm reduction organization. Harm reduction has a lot of different meanings, ways of being described. I like to describe harm reduction as the difference between saying, hey, this is how I'm going to help you, take it or leave it, and that open-handed question of asking, how can I help? There's harm and risky behaviors that a lot of people do all day. It was risky for me to get in a car and drive from Grand Rapids to Holland today. I wasn't going to walk here in this heat. That was too much. But I put a seatbelt on and I kept it going. That helps reduce my harm in maneuvering forward with the behaviors that I was going to be engaging in anyway. So we started in 1998, really with the intention of addressing the HIV epidemic that was showing up across the country and also specifically in Kent County. As we started doing that work, we saw that about 25% of the clientele we were serving had acquired their HIV through the use of shared injection drug supplies. So we were contacted by the city commissioner to start up a syringe access program. So people are able to come into our location and get sterile unused supplies for their injection drug use. From when that first was started, when we first started this syringe access program, we've seen the number of 25% drop down to 8%, and now we're sitting at about 4%. So the proof is really in the pudding. Harm reduction continues to be a common thread of all of the programming that we provide. And it really splits off in two different branches for us. Harm reduction around drug use and substance use, and then harm reduction around HIV care and prevention. My role at the REV project is kind of a dual position. So I'm going out and doing community education around preventing an overdose, what is harm reduction, things of that nature. And then I also work as an HIV medical case manager. So I have a caseload of people who are living with HIV that I carry across time, and I'm helping to navigate any barriers that show up within the medical field, help have advocacy in and out of patient appointments and in doctor's offices. Navigating insurance. Insurance is so not fun. Let me help you with that. So with our HIV prevention programming that we provide, we have on-the-spot HIV and hepatitis C testing. It takes about 20 minutes or less for someone to be able to find out their status on the spot. And then we also offer a plethora, abundance of condoms blue. Check out that back table if you're interested. The main thing that I really want to do is set the table before we turn over to our phenomenal panelists that are here. We have seen the number of newly acquired HIV cases continue to decline, and that's largely due to the use of prevention tools like syringe access programs and like a medication like PrEP. For those of you who haven't heard of PrEP, PrEP stands for pre-exposure prophylaxis. I like to describe PrEP as essentially being the birth control for HIV. Someone that is currently not living with HIV is able to take this medication called PrEP, and it keeps them from being able to acquire HIV. So that's a huge piece of also why we're continuing to see this number of new acquisition continuing to decline. However, we can't continue to discuss the current landscape of HIV in the US without acknowledging and examining the substantial disparities that exist between racial groups living with HIV. HIV disproportionately impacts Black people in this country, specifically Black men who have sex with men, Black women, and Black adults who identify as being transgender or gender nonconforming. In 2021, more than 40% of new HIV infections in the US occurred among Black people, despite Black people making up only 14% of the US population. So that's really when we need to look at that population density. Only 14% of the US population is people who are Black, and yet they account for almost half of the newly diagnosed and acquired HIV cases that are showing up in the country right now. Black women have had the highest HIV infection rates in the country compared to women of all other races and ethnicities. Black trans women account for 62% of HIV infections among all trans women with HIV living in the US. And going back to that idea of PrEP, this birth control for HIV, only 9% of Black people who were eligible for PrEP in 2020 were prescribed it, compared to 65% of their white counterparts in that same year who were prescribed PrEP. So we can't really look at the landscape that we're in without having that acknowledgement and awareness. Because of this, providers, community health workers, and policymakers are really being called to action to address these gaps that are showing up across the country and implement anti-racist, equitable access to care and prevention strategies for people of color who are living with HIV. Another substantial gap showing up in HIV care right now is adequate support for people who are aging with HIV. In the beginning of the AIDS crisis, which was it was over 40 years ago at this point, the idea of aging with HIV at best was a distant dream. It was pretty unheard of. As of now, in 2024, more than half of the people who are living with HIV in the US are 50 years of age or older. By 2030, it is predicted that 70% of folks with the virus nationwide will be 50 or older. So this is a considerable chunk of our population of people living with HIV. One of my favorite piece of statistics to pull out of my back pocket is that there's data that shows that men who are living with HIV, on average, tend to live longer than men not living with HIV, purely because they go to the doctor more. And I think that that's a fascinating little piece of information. The stigma attached to having HIV and the misbelief that living with the virus remains a death sentence helps to explain why folks have trouble accepting the longevity of people living with HIV. It's because of existing stigmas and misunderstandings of the virus that it remains necessary to demand that policies about people living with HIV must include people over the age of 50. And policies aimed at aging Americans must include people who are living with HIV. What could it look like to have legislation passed that is created to center people who are addressing HIV care, chronic disease management, and geriatric care? What could it look like to increase the budget for research dedicated to exploring HIV and aging? What could it look like to develop programs that specialize in the training of healthcare workers to meet the specific needs of America's aging population of people living with HIV? It's because of existing stigmas and misunderstandings of the virus that it also remains necessary for us to uplift the stories of long-term survivors, which is what we're here to do today. So without further ado, enough of me talking, I would love to introduce our wonderful panel of people up here. So as everyone's getting situated and settled, we have a really outstanding group of panelists here with us tonight who have invaluable knowledge and experiences to share with us. And I really want to thank everyone for being here tonight. Can we give them another round of applause? To kick us off, if y'all would mind or wouldn't mind going around introducing yourself and giving a brief synopsis of your personal experience, either as someone living with HIV or in working closely with people who are living with HIV.
I'm Jan Koopman. I served as Executive Director of the Grand Rapids AIDS Resource Center from 1991 to 1996. A real burnout time of, there was no medicine. Everybody was dying. It was a hard time in a lot of ways. And then I took a couple of years off from that field, and then I came back and was the first staff of HIV/AIDS services, which has evolved into Red Project. And the way that really worked is we worked for 7 or 8 years to convince policymakers that harm reduction made sense. And then there was a mayor's drug task force, and after a year of study, they decided we needed neo-chairs. Okay, Jan, find some money and find where to put it. So we did, and Rick was instrumental in starting HIV/AIDS services.
I helped start HIV/AIDS. My name is Rick Alvarez. I've been living with HIV for 38 years now. I was diagnosed in 1986, and when I was told I was positive, I was told by the doctor to get my things in order. You have 6 months, go home, put your things in order. It's like, well, I don't see any expiration date on me, so, okay. But back then, there were no medications at all for HIV except for ACT, and the doses they were giving people were just killing them. So I stayed off of the meds. I started to take the ACT, but I didn't like the way it was making me feel, so I stopped that. And I stayed on medications until 96, and this was after protease inhibitors came out, which are the lifesavers right now with HIV. And that actually saved my life. I was dying at the time. I was so sick that people said I probably should have been in the hospital. But I just started taking the medications, and they worked, and got myself back to right now a undetectable level of HIV, which means at present there is no HIV detectable in my blood system or in my body. I'm able to have unprotected sex with my partner if I choose to, and know that I won't infect him, because I don't have any level of HIV there to pass on to him, which is great. We didn't have that back when I started, but I'll pass it on.
My name is Jose Teixeira. I'm originally from Boston, but was recruited out here, a professor at Michigan State University. When I was a freshman in college, this is when things started showing up in the news. And within a few years, many of my friends passed away. No one knew really what was going on. It took a few years to identify the virus. I'm a biology major, and people would ask me questions, and I really wish I had answers for them at that time. It's been a real struggle. At that time, we were all pretty fatalistic. We were all pretty fatalistic. I mean, if we're going to get it, we're going to get it. I wasn't doing anything different from my friends. I just was lucky, I guess. I remember some of my friends on a very regular basis. I had 7 roommates after college, and 3 of them died. And some of the most beautiful people I've ever known. And then in 1995, Corey was a director in a cocktail store, and it made all the difference in the world. And I just was one roommate, like if he had held on for another year, it was just a horrible situation. And I'm doing this because I was asked by some friends to be on this panel. Basically, it's to honor them as well.
I'm going to do a quick interruption and just give the reminder of really speaking into that mic as clearly as possible so that people way in the back are able to hear also. Sorry for the interruption.
Okay, was this one?
I think so.
Now?
Is it turned off?
No, it's on.
My name's Doug Abel. I met my partner, David Van East, in August of 1988, and I was just up there on vacation, but we hit it off so well that I had been staying with my sister in Indianapolis and drove back up the next weekend, and that was when we really realized that something serious was happening here. So he actually had to have the conversation with me to tell me that 2 months earlier he had been diagnosed with HIV. And so I had to kind of work with that. We did 1 year long distance, we lived in Indianapolis and him up here. And I decided that I was all in. And so I moved in, like Rick was talking about the AZT, he took the AZT. Every 4 hours, 24 hours a day, 7 days a week. And so he was on that regimen. He did get a couple of very strange, opportunistic infections. He got cryptosporidium. And he got that at a banquet that he went to with other people, and it was because somebody in the kitchen didn't wash their hands. So just different things like that happened. But he was told fairly early on, if you hold on for 5 years, new beds are coming that will help. And so he held on for the 5 years, and the beds changed and things started getting better. And I don't even know when he first became undetectable. He had been undetectable for years. He died 13 months ago, but it had nothing to do with HIV. He died of sepsis from a foul line. And so he was very involved with the AIDS Resource Center in Grand Rapids, with the one here in Holland. There was a group that was a non-government group called Terry's Fund that privately raised funds and helped people out with whatever they needed. Since they weren't regulated, they could do what they wanted with the money, they could help with rent or utilities or food or medicine or whatever people needed. We did a lot of AIDS walks, were involved in bringing the quilt here twice, and then we went to the big last display in Washington, D.C. I didn't know what I was supposed to do for this, so I brought some visual aids. I just laid them out on the table and I could look at them afterward. But a lot of pictures from some of the quilt displays. Got a shirt over there that's got a lot of the different kinds of AIDS pins and red ribbon and the different ways they were interpreted. And he also did AIDS educations in the schools further across. He had volunteer of the year a couple times. But that was something that he was quite passionate about because he wanted these kids to know this can happen to you. This isn't just something that happens somewhere else to other people. This can happen to you. And I think probably one of the most important people here in the Holland area was Paul Verhage. And I don't know if any of you know the family or they had the car dealership, but he was a hemophiliac. And so he got the disease at a young age from blood transfer. And Paul was an exceptional person because he just took it in stride. He had this disease. He was going to do what he could to educate people and to help other people not get it. And he said, and he realized that as a straight man, he was welcome into places where gay people couldn't go. So he was very instrumental in getting the word out. And David and I commented, we were at his wedding. He actually was able to get married. They were married a few years. But at his wedding, they kind of broke tradition, and I don't know if it was on purpose or not, but instead of the bride and groom leaving and everyone filing out, they stood at the end of every row and they shook hands with every person so that every person would know that they had shaken hands with somebody who had HIV. I thought that was such a brave thing to do. That's my story.
I'm David Moore. Was a physician, I'm retired now. My partner David Blatt and I did HIV care in Chicago for close to 30 years. Starting in 1992, which was when a friend of mine came and said, "Hey, David, what's this on my foot?" I'd been out to Sloan-Kettering to the first HIV conference that was out there. So I knew what it was. I was KS Legion and just started to roll from there. And mostly friends. Former sex partners, people I loved, patients I grew up. So failed around 1985 when we were losing livers in the market. There was no treatment that was effective. And in fact, the treatments we were giving were producing mutations in the virus, making it harder to treat people. So it was an education by fire into how to negotiate the pharmaceutical industry, the government, the community. It went on and on. It was an amazingly fatiguing and interesting, exciting, tragic time, and all of those pieces were in every single day. But we did it. We developed a 24-bed inpatient care unit in our hospital. It was multidisciplinary team-based. So we worked with everyone in the hospital. Every department in the hospital came to our meetings, and once a week we talked about every individual patient by name. And even the housekeepers attended because they often knew the important things that we didn't know because they were the people in the room that understood what the real suffering was going on. So we learned a lot about how to communicate, how to work with people, how to provide services, and how to support people through their lives. We learned that healing and curing were two different things. And because you couldn't cure didn't mean you couldn't heal, but you weren't going to define healing as the doctor. Because only the person dealing with their own life can understand what it is to deal with it. And yet we saw that happen over and over, and it made me incredibly humble and incredibly proud to be present and be able to look at people can talk more about any of those aspects, but I think what the clinic over there.
I got to do that work with this guy. He had an extraordinary group of nurses. They're high touch, high tech, angelic people. He had the woodwork, and people had a whole variety of reasons. Nobody did this just because it, worked right for their schedule or they, needed a job. People were all very mission driven about this. And some of the nurses really, with all the stigma, took real flack from their families about it. So it's just a wonderful group of people. People are still friends with. I'm sorry that you got told by your doc that you had 6 months. I never did that. I felt really strongly that.
I was kind of taken aback by it.
Yeah.
I was.
Well,
It's like.
He or she was wrong, and I'm glad, and they didn't know. And although most people were really doing poorly during that era, I felt really strongly that people only had a chance to do well if they thought it was a possibility, and I thought it was a possibility. If you're just not open to the possibility of being here decades later, it can't happen. So I think we're both pretty.
Yeah, that's what happened to my partner down in Florida. He was told he was sick and he was going to die, and he was going to die, and every doctor kept telling him you're going to die.
He believed it, right?
And he believed it, and in 1992 I married him. So
Sorry about that.
here I am years later, still here. And my thought had always been, oh, this thing is not going to kill me. I will not let this kill me.
And knowing that, believing that to be a possibility,
Right.
allowed you to
Make changes.
make changes and do all the stuff that needs to keep going. So it speaks well for you. And again, I'm sorry you got that message of that I was wrong. I think I will press on to you guys.
Passing it over to me, actually. I'm good, hang on to that one. So really, I want to spend time in this panel diving into your specific stories, which you've given us a look behind the curtain into already.
Just a touch.
Just a touch. I'm going to pull that curtain all the way back today. Starting off, these next series of questions are really centered around learning more of your story. Most of you, the majority of you on the panel tonight, lived during the AIDS epidemic. Can you speak to what it was like for an individual to identify as being queer or being part of the LGBTQ plus community during the AIDS crisis? And what were some of the biggest challenges faced during the height of the AIDS crisis? Which is a doozy of a question to throw out there. Take your time.
I'll start because I can tell you exactly what happened to me. A lot of my friends, because I was HIV positive, no longer wanted to have anything to do with me. Of course, I lost a lot of friends to the virus itself, but there was also people at my job started looking at me differently, and within 4 months I had lost that job because they didn't want an HIV person there. I was a cost on their insurance that they didn't want to endure. Their insurance premium was going to go up about $1,000 a month just because of me, and they didn't want that, so they fired me. When I got to another job and they found out that I was gay, they fired me on the spot. And their main excuse was because you could get HIV and be a problem to us. And it was all based on the fact that I was a gay man that I could get HIV, and they didn't want that. So there was a lot of stigma back then. People wouldn't want to touch me. They didn't want to come over to my house and use my sister would not come to my house and use a fork in my house. Even though I had to run it through the dishwasher or hand washed and cleaned it, she would still not use any utensils in my house. So I couldn't have family dinners over at my house or anything like that just because she wouldn't do that.
Rick, I'm sorry, am I interrupting you?
No, go ahead.
I was just saying, exactly what you're talking about reminds me of a really complicated part that I felt when I was first telling people that they were positive. Usually, I would also encourage them to think of it, just not to rush out to tell everybody because of all the stigma, but it's such a mixed message because it wasn't something that was bad about them. It wasn't that they were a bad person or this. Usually, when you're hiding stuff, it's because you're ashamed of it. So, at a time where people were getting this huge life-changing news, I was also trying to give them this mixed message that not because they were bad, but because there's so much prejudice that they might want to be really selective about not telling their boss right away, not telling their landlord right away, identify people who would be there for them. But that's a complicated message both to express and to receive. At the same time that you're finding out you have a serious illness. I tried to get across this message, I'm not sure how effectively, for exactly the reasons you're talking about.
Yeah, because it was happening to everyone.
Yeah.
I mean, I was told several times, you better watch out who you're telling, that you're positive. You need to watch out who you're telling, because you can be hurt by it, you can get beat up because of it, you can lose your job, you can lose your insurance, you can lose your house. I mean, back then it was just awful. It was just terrible.
Back then, in 91 to 96, when I was working at the AIDS Resource Center, me as a straight white woman, Dutch, and even go to church, I could relate to some people who really had not had interaction with usually their son, for years and years and years. And now the son was, they didn't know how to cope with it. So I could talk to them sometimes when maybe someone else couldn't, or someone who's gay couldn't. But the discrimination against gay people, you could walk down the street in Grand Rapids holding hands with your same-sex partner, and the gay bars weren't very public, and you could get fired from a job. No teacher would dare come out of the closet. You could get fired, and it was perfectly legal for them to fire because there was no protection. It was just an awful time.
They don't have to have any reason to stay.
At-will
David was a teacher, and so he had to be very careful about who knew and who didn't know. It's actually as big or bigger a step than coming out gay. So it was a second in coming out that people had to do. And even though it is, in Michigan anyway, against the law to disclose somebody else's status, that law wasn't followed up on. And so that's another reason why people did not tell.
It was not unusual for people not to have come out already. It was not unusual for them to hide the fact that they were both gay and usually bothered by their parents. For fear that they would get a shot. And I saw it over and over, and still people would be on their deathbed and their parents would come to town and suddenly discover their son was gay, their son was dying. Sometimes they did walk out and never come back, but usually that wasn't the case. The rest of the circumstance put them in, and at least they had a short period of time. But the fear of that was palpable. Oftentimes, if one partner died, the remaining partner would lose access to their home, to all of their belongings, to everything they had built for 10, 15 years together, because the parents of the person who had died would come in and take everything and completely ignore the partner, or worse, treated badly.
The partner's name wasn't in the obituary. The partner wasn't allowed in the hospital room at the end because he wasn't the family.
My partner's sister came in and took everything of his, everything. Left me with nothing except the rent bill that I had to pay because his name was on the rent and he wasn't going to pay it. But being I was living there, the landlord made me pay it, so.
In the obituary, usually said they died from cancer.
Yeah, that's what he did. They
Or
did.
died after a long illness.
No, he died from cancer. Is what Jaden died from.
This even would complicate these very intense discussions we would have in the intensive care units with our patients about how much they wanted to have done. Usually, in a non-AIDS situation, the person will just say, the discussion is more about, are they just fatigued with medical interventions, have they been through enough? Here, sometimes patients will tell me, just let me die before I have to tell my parents that I'm gay and I have HIV. And talking through that with people, that's why they didn't want to be resuscitated, and that maybe we could do some workarounds that they didn't have to tell them, the sister could tell them, or something I could tell them, was just different from most medical situations. and just what I thought, when you were saying that you were able to talk to maybe Dutch church-going people, one of the really wonderful things about the diversity of the nursing staff we had was we had a good old girl Southern nurses aide who could talk Southern talk to people, families from there, black staff that could talk black church stuff to those folks, Hispanic, particularly housekeeper who could talk that, so that usually there's somebody on the staff who could connect with the family and who often loved the patient and help connect those dots.
One thing, it was kind of surprising to me. One of the populations that was the most supportive for HIV positive men was lesbian women. And over and over and over again, if they were in the medical field, if they were just friends and helping to support people, they saved a lot of lives.
There was no federal money. There was no federal money for HIV/AIDS care. Millions of injected drug users and gay men had died of AIDS before the Ryan White Care Act came along, which was named after a white teenager from Indiana who had hemophilia. Then suddenly there was federal money for HIV care. But before that, it was the gay community raising tremendous amounts of money in bars. And without the gay community, we couldn't have gotten through the first 3 or 4 years that I was executive director, because there was no government money for it.
If a person had to be AIDS defined for 24 months, 2 years, before they could get disability, which means they had to have a TSO count under 200, or have had PCP, which before treatment then a 9-month life expectancy, or pharmacy. Yes. So oftentimes nobody could live long enough to get their Social Security benefits. It was an unbelievable situation where it would be much better if you had end-stage kidney disease, because then you could qualify for this. It was a form of discrimination that took years to resolve.
If I could just take a different perspective, because I was in very supportive Jacob, and we didn't have to worry about being discriminated against in Boston because Massachusetts had anti-discrimination clause for gay men. And the healthcare, they're one of the first and still probably most important medical groups was the Family Community Health Center, which really did a lot of the clinical trials for some of those drugs because no one else wanted it. So in some ways that was better, but it was also not so great because you became desensitized somewhat because so many people that you knew, that lived with you, were passing away. So I'm not sure that, yes, I think, West Michigan probably was a little was a little more discriminatory for reasons actually. Yeah. But you're talking about individuals with disease, it doesn't really matter too much. They're sick, they want help, and they don't know how to get it. And they're scared, they don't know what to do. And I think that's the same in whatever environment you're in. I will say, you just reminded me about Social Security. I know that there were companies that were buying out Social Security, not life insurance, life insurance plans from who were dying, and it was really predatory. But they needed the money, and so they took that.
One thing about the treatment was actually paid for it. Dave was very lucky; he had good insurance. There are a lot of people, that's one of the questions I was thinking of when Olivia was talking was about all the prep and the medicines now for these kids. Who pays for it? How do they pay for it? And what happens if they can't pay for it?
That's a great question.
And that's why, when I started taking meds and getting healthier, and was invited to join in on helping other people with this disease, I joined the council here in West Michigan, the HIV/AIDS Council, that helped make referrals for what needed to be done. And then I joined the Michigan PWA Task Force, which is it was an advisory body to the Department of Health for the state of Michigan, and we helped create what's now called the Standards of Care for persons living with HIV in Michigan. And it is the Bible of HIV care and how to take care of somebody and what is needed to be done, what's needed for them. I don't know, I've been out of this story for about 20 years now, but I don't know how that's still going because the task force was disbanded in 2002, I believe. And I'm not sure how they get their advisory from people living with HIV, but that's part of the mandate of the Ryan White Care Act, is that in order to get funds for HIV care, you needed to get input from the HIV community on what they needed and have that as part of your plan. So they needed people that lived with HIV to be advisors for them. And fortunately, we got a lot of work done in Michigan in the care for HIV, and Michigan was the standard for other states and how they started up their care and programs for HIV. So I was really fortunate to be part of that, because when I started out, like they were saying, when I started out, there was nothing. If you wanted HIV care, you had to fight tooth and nail to get it. You didn't know how you were going to get it, and you didn't know how you were going to pay for it, because you knew it was expensive. I mean, one medication for me is $12,000 a month. So, thank God I got good insurance. But I wouldn't have had that if we didn't set everything up like we did. So, fortunately, we set that stuff up, and I got to take advantage of it. So, I advise anybody that has HIV to get in contact with the health department and see what programs are available from the state of Michigan so that you don't bury yourself with HIV cost, because it is such a costly disease to live with. So.
Two thoughts. One is, in terms of stigma, this is actually fairly far into things. There's a patient I took care of who I still don't know his real name. He was a dentist in Michigan and was absolutely convinced that he would eliminate his practice if anyone knew that they had HIV. So he paid for his visits in cash, he paid for very expensive drugs that way, and to this day I don't know the guy's real name. I just, the stigma and the fear was that prominent. And then also this theme about organizations coming into existence. In Chicago, we were very lucky that people, again, coming out of the woodwork to just realize that there was a need. So Chicago House, a housing situation for people who had been kicked out of their homes, was just people who were sort of self-appointed, took this on, and as you can imagine, it's a lot of work to set up something like this. There was a Meals on Wheels for people with HIV, which still exists. Again, just people seeing the need, and nobody else was doing it, so they just take it on. Another residence of one of the Venture House at our agency, there was a local restaurateur who delivered food every Thursday night for like 10 years. He really kept this up because hospital food's hospital food, and we really were trying to encourage people to eat something which wasn't going to be hospital food. So this guy kept just donating this for a long, I mean, he really kept it up. So there were, and there was this had good response along with the horrible stigma stuff happening.
I'm gonna pop in with that as a segue into my next question. Can you discuss the response to action by community and world leaders with addressing the HIV and AIDS outbreak? And then also, can you discuss any significant moments or movements within the queer community that emerged as a response to the AIDS epidemic?
Well, I can can tell you when I started out, the world leaders and national leaders, and even the local leaders, wanted nothing to do with it.
Didn't say the word.
They wouldn't say a word. We couldn't get the President of the United States to even utter the word AIDS or HIV. I mean, that's ridiculous. Millions of people were dying on his project. He wouldn't even speak the word, wouldn't even address how to care for them, what we were going to do about the epidemic. It was a gay disease. It was affecting the Hawaiians in this country, so they were going to deal with it. And it's so sad. I mean, we lost millions of people. It was pretty much like the last epidemic we just went through. But because it was a straight epidemic, and it was hitting and killing everyone, and millions and millions of people were dying monthly, they finally did something very quickly, and there was a vaccine out for it. We still don't have an HIV vaccine. But they came out with a vaccine for COVID within months, basically, because the president started this rushed program, and expedited program. Why don't they expedite the HIV vaccine so we can finally put an end to this disease? But no, they can't do it. It's too costly.
But the third International AIDS Conference was in Washington, D.C., and George H.W. Bush came to address the crowd, and I would say half of us stood and turned our backs to him, because he was one of the us who would do anything for us, wouldn't say a word. And yet,
In fact, he cut programs that were started when he got in office.
I was on the AIDS Interdisciplinary Advisory Council for Illinois in 1985. And at that time, we addressed the legislature. I think two people came. We got to at least address the committee who was responsible for our report, and they all came and put to them. We asked them to start a new program now. It was 10 years before the revival and I got funding to start that program.
Well, I was a legislative director when I was at the task force, and we would go to DC during what they call AIDS Watch. We had local events that we did here in our federal or our state government, but we would go and we would talk to our senators and congressmen about the HIV epidemic and what's needed. And when I walked into one of our congressmen's office from this district right here, I had the door slammed in my face and told me he did not want to talk to me. Did not even let me come in the office. Slammed the door in my face and said, call my secretary and make an appointment. I already had the appointment. I had there at that time for an appointment I had with him. And he slammed the door in my face and told me to call his secretary and make an appointment.
There was incredible urgency in young people who were infected. They knew they were going to die, or believed they were going to die. They believed they were going to die soon. And they were angry, and ACT UP was the community organization that came out of that, and they were an incredibly effective organization. Yeah, but was there a chapter in Grand Rapids?
No.
Okay. They were active in Chicago and New York, San Francisco.
Yeah, no, we couldn't get one going because of our local government.
I think the legislative action we got was directly out of that community activity, and it should be an example for other things unfortunately we're facing right now.
Well, I know if it wasn't for the 30 of us on the task force, Michigan wouldn't have the programs that we have now. Because of the 30 of us that were on there, we have excellent care in Michigan. So.
And the actions of ACT UP are what made NIH, Dr. Fauci, change the process of drug trials.
Yeah.
You know, and it ended up after they called him a murderer for years. He cried when Larry Kramer died.
Yeah, I never cared for Dr. Fauci at all because of the problems we had with him in the HIV epidemic, and then he came up and he was the hero of COVID. So I'm glad he did a good job with that. He still has to answer to me for what he did during the AIDS epidemic and why he didn't address it well what he did. So it was awful.
The AIDS project, AIDS was another thing that I think just the sheer magnitude of that surprised some people and got a lot of attention. And I think
Well, when it covered the entire national wall from one end to the other and then beyond, I think people took notice when they saw the aerial photo and see how many people had died from this disease.
I went up to the monument and I got that same picture that was on the news. And we actually got there, and
Did you ride the bus or did you come on your own?
we came on our own thing. But we went over to the display early one morning, and because we had experience with other things, they actually let us be part of the unfolding of part of it.
Were you there in '87 for the March, the first March? So, now we get Tennessee. Yeah. So '87 was the first March on Washington. And that's when the first umbrella wasn't quite that bad.
This is that I was able to do the last time to give you the first one fully displayed because of the magnitude of the still wasn't big enough to display it.
But it was very empowering being with thousands and thousands of people marching past the White House and cheering. And I think one of the things that probably galvanized a lot of people to really think about AIDS was when Rock Hudson died. Because Nancy was a good friend and everybody was trying to figure out what would happen after Rock Hudson died. I think that made the national news and people started thinking, hey, if Rock Hudson can get AIDS and die, it's not just those deviants.
Well, until they labeled him deviant, and that story came out, yes. Then he was a bad guy. But
He was a hero.
he was here before that, because, he was the one that brought HIV to the forefront of people's minds, and things all kind of started changing after that. And then when Michael Jordan came out and said that he had HIV, Magic Johnson, that's what I meant, Michael Jordan.
Yes.
But when Magic Johnson came out and said he had HIV, then it opened up a lot of the awareness in the black community that they could get it too. So that started rolling all that. But, until these high-profile persons that weren't gay and weren't part of this deviant community, they got it, then people started realizing, well, maybe I can get it too. And started thinking, how do I protect myself? So when I'm told now.
On a local level, the first 500 patients they had at our hospital were the most sweet, appreciative, lovable, loving, courageous, inspiring people. My first jerk was a patient like 501 who was complete borderline lunatic, scared me and everybody else. But what I was saying about was on a local level, the way that I think the hospital staff got so wonderful about HIV was they were just won over by the guys and the women. It was overwhelming the guys at that point. They just charmed the heck out of the X-ray department, the housekeepers, and charmed in the seriousness in a really profound sense. I was just thinking about, on the big stage, Rock Hudson or those guys, but the little stage of just locally, just these individual, otherwise anonymous people were so lovable. They really won over people.
Like I said, the attitude changes when you face death. You don't want to be mean anymore. You've got only short time left anymore. Make sure that you don't have too many things to atone for when you get up there. So.
He gets always back up anyway.
No, but there were a lot of gay people, HIV positive people that would come in that were just happy-go-lucky. It's like they were free now. They didn't have to worry about things anymore. They knew they could get care now. So they're happy-go-lucky guys.
Our next question is something that's already been touched on slightly by different people so far. It's really centering on stigma and the role that stigma can play. Oftentimes, I hear it addressed as stigma being more deadly than the virus itself, which I really believe. Can you speak to what ways does or did stigma surrounding HIV and AIDS impact you or your loved ones' lives? So external stigma, But then also, how does living with HIV impact your relationship with yourself and with your body? Have there been experiences of internal stigma?
I can tell you there's been times where I've felt that, well, if I'm going to die, why do I need to take care of myself? You know, why do I have to not do the things that they tell me I can't do anymore that I used to do? You know, why do I have to stop having fun just because I have HIV? You know, if I'm going to die, I'm going to go out having fun. And like some of the other people, I started racking up credit cards and things like this. And once I realized I wasn't dying, I'm like, oh my God, I got all this debt, I got to pay off. But I wasn't in the deep as some of the other guys told me. I mean, they maxed out their stuff because they thought they were dying. Some of them did, some of them didn't. Some of them got real big problems. But, you know, you have a whole big mindset change. But the stigma around it cost me a job, 2 jobs actually, a home, friends. I mean, back then it was very stigmatized. It's getting better now. I mean, it's not as bad, but I still can't see my great nieces and nephews because of my niece that married my nephew that will not let me come to her home. She will not let me come to family functions. If I'm going to be there, she will not bring the kids or be there herself. And that's really sad because that makes me miss out on all the family things because I won't interrupt the family just because of her. It's them that are missing out. It's kids that are missing out. It isn't me. They're growing up without a great uncle, and I think I'm a pretty good uncle. You know, I kind of spoiled the rest of them I have, so you'd think that she'd want her kids to go too, but yeah, that's her choice.
Well, and the story you're describing is that she's categorically disinterested in information. It's not that she's like trying to find out it's the safe or unsafe, or it's just categorically just all about this. That's a statement.
It's the stigma.
Yeah.
Well, yeah, I know it's hate, but
From
that's
the,
part of stigma.
Yeah.
It's hate.
From the medical standpoint, there were procedures in our office that you would never do otherwise medically. When I would test people for HIV, they didn't put that down in the chart, put down this little bracket, secret signal to myself, and people were tested by a number system as if you were going to a code check, so their name wasn't associated. So I came to number 914, and you had to bring that back to find out the result because there was no name associated, because people were that concerned about a list and what the government was going to do to make sure that you would never, in medicine, normally if you ever have your blood drawn, they ask you your birthday again, they look at your little arm, man, just have your blood count drawn or something. This is so different, all because of stigma.
Stigma and fear, and it was realistic fear, because there was talk in Congress of putting people in camps. It actually was discussed and realistically, because of Cuba, which is a nationalist.
They wanted to get all the prisoners down there and put HIV positive people
Cuba was
down
actually
there.
went to a camp and was kept in a camp. And looking at the nationalist kind of government that take over in this country, so that it's not like it's a done kind of situation. We have to remember that we're fighting for a lot of freedom, which includes that for this time, and we don't want to go backwards.
We can see why I love the government.
I think, you're talking about the patients just winning over the dietary staff and the house cleaning staff and the nurses. And if there's a good side to HIV, I think other people started to see gay people as multidimensional, caring human beings, and maybe in some way that speeded up the move toward equality, because gay people were stigmatized. And through AIDS, so many people saw full humanity.
That's true, but then the right decided to turn that away from us because they couldn't get away with it any longer and turn it against trans people.
Yeah.
And it's the same kind of fear mongering that we need to be there
It's the
supporting
same fear
ourselves.
and hate they had.
We've talked a little bit already, both from panelists, and I set the table with the idea of looking at kind of where we are in terms of the landscape of HIV and AIDS presently.
I'm so tall, I didn't know.
You're just fine. So HIV and AIDS is still prevalent today. Over these next couple of questions, I'm wanting to dive into kind of comparing experiences of treatment and healthcare across time. Starting off, what ways were treatments made available to clients? What was the entrance into treatment looking like, and how has that changed over time, if applicable? I heard you say you were immediately given an expiration date of 6 months, the medication being AZT, and having to take that every 4 hours, every 24 hours. So walk us through that entrance into treatment and how that shifted over time. What does that look like now?
Well, after I left the doctor that told me I had 6 months to live, it took me another 7 months probably to find a doctor. And the only way I could find a doctor was finding somebody in the community who was HIV positive and asking, who's your doctor? I need a doctor. So that's how I found my doctor. And I went to him and discussed my options, which at the time it was AZT. And I went ahead and started taking it, and everything was fine until I started getting sick. And I was watching my partner who was on AZT just hurling and deteriorating through his stuff. And I said, no, I'm not going to do this. And my partner said that he didn't want to do it anymore, so he talked to his doctor, and he started doing the experimental powdered DDI and D4T, which what I did is stir it into water and try to drink this stuff down. Oh my God, it was just horrible. And how he could do it, I don't know, because I couldn't do it. And I just stopped taking all drugs. But I still could not get a referral for alternative care besides HIV. I couldn't get a referral from my primary care doctor who was taking care of me for HIV because I was HIV positive. Nobody else outside that community that was helping the HIV people wanted to do healthcare on HIV positive people. So it took me forever when I had to have orthopedic work done to find an orthopedic surgeon who would help me. I think I laid around for 7 or 8 months waiting for a referral that worked for me to get my knee taken care of. And that's why today I'm still having problems with it, but okay. That's the way things go. But the medications went from the AZT and the D4T and DDI that Jim was taking to these white tablets that you had to slowly chew up. I can't even remember the name of that, but oh my God, it's just, yeah, it was just this big tablet you stuck in there, you had to wait for it to dissolve. And before you could even drink, you had to wait for the whole thing to dissolve down. And I mean, some of these medications, I know they were really trying to find things that would help, but some of the stuff that they came up with was so terrible, not only to take, but to tolerate, and the side effects from these medications were just crazy. And then when they got into these protease inhibitors, before that they were working with nuclear medicine. And I still take one of the nuclear medicines, but the other one my body called what they called the resistance of some sort of resistance, where my body became resistant to the med, and it no longer worked. And that happened with the other nuclear medication that I was on, so I can no longer take that medication. I cannot take AZT anymore because of when I first started taking it. Now that I stopped, if I started taking it again, it would kill me even worse. So I can't take it at all. And there's 400 or 500 drugs that I have taken in the past that I became immune to. My body stopped working to it, or they became resistant to it, because the drug is constantly finding a way to mutate itself so that it can survive and continue to make other viruses. Because how HIV works is it's this little molecule that floats around in your bloodstream, and it starts making HIV inside of itself. And as it keeps growing bigger, all of a sudden, it's too big to hold it and contain it anymore. It bursts open, and 1,000 or more HIV cells are now ramped and running through the bloodstream, and it keeps multiplying like that over and over again. And it's so fast that the body's immune system can't keep up with it. So that's what they try to do. They try to stop it growing into that, from that wall into the virus itself that explodes. They're trying to stop it from attaching itself to the T cells so it can't infect that and make it, because it'll transfer that into an HIV cell and it starts making HIV cells too.
David was admitted early on during the first year we were together. He was admitted. It was for the cryptosporidium, and they couldn't handle it here in Holland, so he had to go to the Grand Haven Hospital. And when he was up there, he had a big sign on the door. And so I don't remember exactly what it said. It didn't say HIV, but it said, high risk, do not enter, all this kind of this kind of the gown and mask and the whole 9 yards on it.
They still do that to this day.
And as far as the doctors go, he was fairly fortunate around here for primary doctors, but he has, for the last 20 years, relied mainly on with a clinic up in Grand Rapids for his HIV care. And so anything that went on had to be run through a series of doctors to make sure that everybody's on board.
So it was in the mid-1980s when a laboratory test was developed that actually changed the whole treatment scenario, when they could actually count the number of viral particles in the blood. Up to that time, they were giving drugs and didn't know what it was doing because you couldn't quantitate the effect of it. You couldn't look at the blood and say, well, it dropped the viral load down predictably and kept it down. So what we were doing was dropping it, and the virus would mutate, and the level would rise, and people would get 6 months to a year.
When they weren't even actually tracking the HIV itself, that didn't come out until the RNA based.
So it was mid-1980s. When that happened was the same, mid-1997, 95. So it was protease inhibitors developed at the same time. Suddenly they realized, gosh, this drug is so powerful, it knocks it down to undetectable. If we can put that together like you do in chemotherapy with 2 or 3 drugs, maybe we can keep it suppressed. That trial worked beautifully, and voila, treatment existed, but it really required that laboratory development. Without that, the scientists that were doing drug testing didn't really know what they were accomplishing. And it is a slow process of science. That was 13 years into the epidemic, and we had people being upset in COVID after 18 months that it wasn't all figured out. You go through things. Yeah. So I think what we could learn from this epidemic in the past is to be patient with science, to support the scientists, to push the politicians, to fund the scientists, and help us move forward. And when we get the next one, hopefully we'll do it.
Just in full response to your question, early on, even before AZP, the only thing we could do was a sort of reactive treatment of secondary infections. And so the entire medical approach was somebody would get a bad pneumonia, treat that, somebody would get a bad diarrhea like the cryptosporidium. And for a bunch of those infections, including cryptosporidium, there was no treatment. And along those things evolved over time, but I'm thinking that the ECT that was every 4 hours around the clock was nightmarish. At that time in history, when there was literally nothing that could be done in preventive fashion, it was pretty seductive to try that, just to get your head above water. Everybody was drowning. And so I just want to be fair historically about it turned out to be dumb, because it turned out that you had to use multiple drugs in order to avoid the whole resistance issue, because the virus does mutate so readily. But this is all happening in real time, and I just, again, in response to your question, it seemed at the time pretty great that there was something you could do for the virus itself. It turned out to be way too preliminary, but everything. Her hood's drowning, so we're just trying to keep her heads above water.
I give hope to the AZT. I know people who wanted to be on it because it gave them hope that they might survive this or live long enough to find something new. So it wasn't, I mean, we're saying it was a horrible drug, but it had its purposes.
It gave people hope, and I must admit that in the old days when church-going lady that I am, when somebody died and they had ACT, somebody went there before hospice got there, got rid of the drugs because somebody else needed it.
Oh, that happened in the 90s for Reese and others, because when he died, I went over to his house and grabbed up all his drugs because somebody hid the Crixaban that he had. He had 2 months worth of Crixaban, and somebody couldn't get it, so.
This all stays in this room, okay?
No, it's in the past.
Yeah.
Yeah, they all have been passed away for quite a while now, so I don't have to worry about that. But yeah, I mean, that's the way it worked back then. We had stashes in the hands office of different medications that we would have there for people who needed it, because at times they couldn't get what they needed, so we made ways to get it to them. That's all of my growing up with HIV is we took care of ourselves, and that was the only way we were going to survive, is we had to do for ourselves, we had to fight for ourselves, and it wasn't until we fought and won that we get the things that we have today, which is great.
The big reference to oxymoron, a wonderful bureaucrat. There was a woman who ran the AIDS Drugs Assistance Program, the federal program run by HD to pay for HIV drugs. And with the way other bureaucratic programs work, there was like a 2-week delay between when the person would fill out the papers and the drugs would be approved and the pharmacist could dispense them. So I called up the woman that runs this and explained that that would be a critical lapse in the treatment so that resistance would happen. She said, "Oh, I didn't know that." So she just fixed it that day. Yeah. So there were people who really wanted to do the right thing and needed information. This is in contrast with your niece, or whatever it was. That one just wanted information. As soon as she had it, she did the right thing. And I don't mean to be trashing your family, but your description of this person.
I understand.
In 2024, to still cling to the hate thing,
Yes.
it's just,
Oh, to lay on to all those myths and disbeliefs that are out there. You know, everybody has these ideas of what's going to happen. I mean, they aren't going to go after children. We are child molesters, so we can't be around children, number one. And then,
Our groomers,
yeah.
you were.
And she doesn't want boys to see that kind of lifestyle because she doesn't want the boys to get any ideas. It's like, sorry, but you're going to have one anyway. I already know. I already know you're going to have one anyway. He's too much of a mama's boy for you, not that. But, you know, it's just unbelievable the way that she still believes it.
So I'm gonna see if I can squeeze 2 more questions in here before we open up to the audience and get any questions that you might have. First question, just a brief answer, but first thoughts that come to mind. What pitfalls or gaps in care have y'all experienced in your care or in the people who loves care? And what do you hope to see or expect to see in the future to fill those gaps in healthcare?
single-payer universal coverage healthcare system. It's painful. Every other advanced country does it. It's so obvious we need it. It's painful. One of the reasons I think we both retired is because they don't have one. And it just became too frustrating. But just other people's thoughts.
We almost had it. Oh, we almost had it. We were so close to having universal health care. At least we got
Sounds like,
Horrible car accident. Yeah.
So the advantage of living in the north is that we have precedent that is probably funded health care. If you go to the south, in a state that doesn't participate in the Medicaid program because we're not federal funding, those poor people suffer and suffer greatly with AIDS and everything else. So be grateful that you live in the north.
yeah,
I don't know too many gaps that we have in our healthcare here now. I mean, we've had several in the past, but right now, I don't
health disparities, racial health disparities.
know that.
People of color just do not have the same access to quality health care. And for lots of reasons, but that's huge. And in the South, there is more stigma, and there's, the Medicaid expansion states. It's just awful.
I don't think it will change for the black community until we do the universal health care. Because, first of all, they gotta find their own insurance. And if they don't have insurance, they have to pay with cash. How are they gonna pay with cash when they're on such a little income? I mean, it's an uphill battle. So the black community has a lot of struggles. Plus, they have their own internal stigma within that community that causes them to have more problems of getting care, because nobody wants to tell anybody they have HIV, and if they're seen going into that clinic or that doctor's office and taking care of people like that, we'll spread. So, they don't even seek care sometimes because of the stigma that's in that community. I tried to do something about it when I was in the task force, but me and the white man, what can I do is to go in and speak to the black community. They listen, but they don't listen at all to me. So they had to have somebody with a voice of their own community to talk to them. And that was not me. But we tried.
Y'all ready for the last question?
Sure.
Well, it's a hefty one, that's for sure. As we celebrate aging with the virus, we must also acknowledge that so many who came before us did not get that same privilege. What are some ways we can continue to honor the memory and legacy of those lost during the AIDS epidemic, while also advocating for ongoing support and resources for those living with HIV and AIDS today? What do you think that some of the most important lessons that today's queer community can learn from the experiences of those who've lived through this HIV and AIDS epidemic? I know, it was a hefty one.
Part of that revolves a lot about the education aspect. If people are educated and they know it's actually a fragile disease, fragile virus, if you take precautions, you can avoid it. I was together with my partner for 35 years, and I'm still HIV negative. So it can happen. But people have to take it seriously enough. They have to be their own advocate, I didn't know it's like talking about universal health care is going to be the big thing, because I think cost and education are the two things holding that are allowing the virus to remain a problem that it is.
I think not having a decent public health system in our country is part and parcel of that, because they would move out of that education, and we're sorely in trouble.
I think a misunderstanding that happened the first time around, and that I hope the education can address, is sort of twofold. One is that people sometimes thought, okay, I'll just get infected and then I know I have it, nothing to worry about. No, it's way more treatable now, but all the people we saw dying had horrible. It wasn't just that you died. You had to go through horrible diarrheas and horrible shortness of breath, dementia. It was ugly. And so I think having people be clear that this is not something, you're not a bad person. It's not.
Every time somebody would say that to me, I would just look at them and say, "You want my life? Really? You want to go through what I'm going through?"
Be clear with people about that.
You better think about that a few times.
Yeah, and I forgot the other part of the pie, because I'm getting dumber every 20 minutes. They'll think they
Well, and the other thing is they think that once they get it, they don't have to worry about it. They don't think that the consequences of what happens when you get infected. And it doesn't make sense.
Yeah, that's, a lot of it is, like Rick was saying, originally, you go in and the doctor tells you you're HIV positive, there was a death sentence. Now then, there are drugs, and it's more of a chronic condition. It's a treatable condition. You can't cure it, but you can treat it, and you can keep a lot of the bad parts of the virus down. But that just needs to be spoken of more, because, you know, there are people that are called bug chasers, you know, that want to get the virus. And that was a lot for me to try to wrap my head around, because it's like, having seen what it does to a body, having seen how much it costs, having seen all of the negative parts of having it, I cannot wrap my head around why somebody would purposely expose it to it.
I think the best thing that I would like to see would be a vaccine. I think, and that would be a way of, you know, remembering the people in the past is how much they actually pushed for a vaccine. And let's not rest on our laurels now that, you know, it is a treatable disease. We still want that vaccine. We need to keep pushing for that.
To answer your question a little bit more, what I do now to talk about HIV and get the awareness out there in the community, I don't anymore. I used to quite a bit, but I got burned out. You know, when you work for 20 years, telling people about it, you just get over it. You're done. You have to take a break from it and step back and say, okay, I've done my work for 20 years. Now it's your turn. You go out and you do it. I've started getting back into it. Like tonight, I was invited to this panel and I agreed to do it. But I haven't done a panel for 15, 20 years now. Used to be very active. Somebody would say something about HIV, and I was right there. And, you know, I was the knowledge, but if somebody became positive in Grand Rapids, it was either me or Bob Greenhoff that they went to see, because we were the ones they knew that had it and had been out there, and we knew what we were doing, and we knew the people to speak to. So it was good that I was there and Bob was there. But it was really hard, you know, to be the person that everybody wanted to question about HIV, and my phone never stopped ringing sometimes. You know, it was that bad. But somehow I've stepped back and I haven't been doing anything. You know? But I think the awareness is out there now, and the point of people knowing that this is a treatable disease, it makes anybody's job a lot easier. Right? I know that the HIV prevention work is still needed. It's just, I can't do it anymore.
It's not in the news anymore,
No.
and that's too bad in a way.
Because
Because it's not in the news, people think it's gone. And we need to make some noise sometimes that it's still here.
Yeah, thank you all so much. Yeah, let's open it up to questions out here. So when we do that,
issue of the vaccine is brought up.
hold on one second. I think we're gonna get you a mic. We have a loop system, so anybody with hearing impairment come here and if you talk in the microphone.
Okay.
Sure, you talk in the microphone.
Can you hear me? The issue of the vaccine, how close is that? Is it anywhere near?
there's no funding for an HIV vaccine at this point. Yeah,
There are people who get vaccines, always have been and always will be. It's a retrovirus, it lives inside lymphocytes. You can't get into the lymphocyte to get to the vaccine because some of those lymphocytes are in sanctuary sites like the prostate and the brain. They're dormant, they're not exposed to the flood that's flowing through the rest of your body. So they have not yet found a way to label something that can get into those sites or to activate those cells so that those cells will uptake the drug. And until they can do that, it'll hopefully eventually happen, but that's why it's so different from every other kind of vaccine that we have and why it's been so frustratingly hard. The last trial was hopeful and it failed quickly. So even with the best scientific minds and theories,
Is it just the rapidly changing nature of that virus that makes it so hard, or is it just the location that it resides?
I think it's the location. It's the location.
I'm not sure if this is necessarily a question, but I wanted to give my own experience that I'm currently in high school, and in my required health class, we were taught about HIV and the ways to commit it and the ways to be protected, and I think it's such a big step that you can do that in school now, and it was all accepted, like, there was no judgment between who you decide to be with or not.
Wow.
I go to school in a more religious city, New Zealand.
Wow.
And so
Wow. That's very good to hear.
I want to follow up to that. I went to school here in Holland, and I went there like 4 or 5 years ago. And when I had sex ed, our sex ed teacher told you if you got HIV, you were going to die. And it was just very negative. She made it sound like bad people deserve to die. And it's just horrible to see how much people have changed.
yeah, I heard the opposite.
That's in 5 years. Yeah. Wow.
I'll project. I went through the same time frame a lot of you did in the early 80s and 90s. I worked for somebody who had HIV, and the office kept me out of the loop. I didn't know that he had AIDS at the time. When he was very ill, he had one of his eyes removed, he had a prosthetic, and died probably within 4 to 6 months after I had started working there. And looking back at that time, it was a horrible time, as most of you have said. I cannot imagine what it would be like today. It would be 10 times worse. COVID, okay, it's a bad disease, and we went through a horrible time with it, and you had a lot of people that were very negative about it, and wanted their freedom, didn't want to protect others around them, by wearing a mask or getting a vaccine that was available. But today, if the AIDS virus propped its head up and started to take off again, I can't imagine what people would do to other people.
We worked in those games.
Well, considering that you get death threats just for being on school board these days.
Yes.
Yeah, it's a good, and sadly, that's, okay.
What is the lag time between exposure and detectability?
6 to 8 months.
It's
It's quicker, not right, 3 to 4 months.
But two actually, you could be ill within 2 weeks, 14 days, and then the antigen test can be detecting that virus pretty much at that time. So yeah, it doesn't take a lot of exposure.
I really see that now in football, so.
And the acute infection can be really sneaky, even for docs that mostly take care of people with HIV, because it can so resemble just you're having a virus, because you are. Some throat, some salt glands, a little fever, and then you get better because it's just the acute infection. So there's a phrase in medicine, the index of suspicion. The index of suspicion needs to be really high, and it's again easy to miss, but with the newer tests, it's much more quickly detectable if you think of it.
I think one of the things that's been positive in the last 6 months is that the American Red Cross will now allow payment to donate blood. And it is so
Back to the
so
government.
long.
Now we can just get them to take undetectable blood as well, because That is St. Paul's.
But thank you all for your input on that. I mean, I think those of us that are related, we all know we lost friends and family. And it's a lot of music trails, and I feel for all of you that lost it.
Thank you.
Anybody else? Question, comment?
If there aren't any other questions, I have one that I wasn't able to get to in my thinking, so I could always throw that out there. But I do see a hand in the back.
I just wanted to forward down to Olivia. You talked a little bit about PrEP, which is pre-exposure prophylaxis, but could you talk a little bit about PEP as well, which is another option for individuals that could be exposed?
Absolutely. So PrEP, I described and explained, oh, I got a fancy microphone attached to it. I talked about PrEP, equating it to the birth control for HIV. I'm going to use another pregnancy analogy for you. PEP is essentially the Plan B pill for HIV. So if someone has had a potential exposure to HIV, they are able to take PEP, post-exposure prophylaxis, within a 72-hour window after that exposure, and it helps to reduce their risk of acquiring that HIV after the potential exposure. It's a 28-day pill regimen after that exposure is prescribed.
How effective is that?
Great question. It's got a high effective rate. Looking it up.
I
Or we
know-
can ask one of our providers.
I know one of the nurses at David's Dentist actually did get a needle poked through her glove when she was working on David. And I know that, you know, they all knew and everything was immediately put in the process. And she did not convert into be positive, but I didn't know all of the details on how much she had to do.
Over 80%.
That's a pretty solid efficacy rate.
Yeah, considering that you have to take the noxious pill for every day for 28 days, so those failures are probably failures to actually comply with what's needed.
Yeah.
I was
over 99%.
PrEP is over 99% effective.
Yeah, but I was just going to chime in because I actually had a coworker that had to take that after she had been exposed, showing a vacuum at work, and the customer had cut his hand, and she went through it. She kind of kept us all like up to date on how it was going, how it made her feel. She was very open with everyone, so everyone that worked there was able to learn and experience along with her as she did that.
That's great.
Are there any other audience questions? Y'all have one more in you coming from me?
Sure.
All right, let's do it. No, it's more than fun one. How do you feel the portrayal of the AIDS epidemic in media and popular culture has shaped public perception and understanding within the queer community and beyond?
Other than negativity, we really haven't done much to show it. I mean, there is no positive news that's broadcast about this. I mean, if it wasn't for you guys just telling me, I wouldn't know anything about that. I knew about PrEP, but I knew nothing about that. Why don't they advertise this stuff? I mean, they do PrEP, but why not that? To say, you know, if you get exposed, there's a way to take care of yourself. I mean, it's almost, like 80% is almost as good as a vaccine, folks. I mean, if you get exposed, go take this, so you don't virus.
Well, you can't watch television without those crazy, way too cheerful ads. People bathing and jumping. And then in the facile language that they took out, this is going to, potentially do bad things to you.
All the side effects.
That's not how we need to be running health education, sex education, and medical education in this country, but that's what we're doing right now, in terms of the media, as far as I can see.
No, the media's played very little role in any progression of HIV. Anytime something comes out or something new comes out, no, they covered the protease inhibitors, but it was like very short period of time. And now they don't even talk about HIV.
I'm trying to think, you're talking about in the media, I'm trying to think of any movie or television program that has a positive portrayal of an HIV positive or AIDS infected person. I
Or
can't-
go back to, Philadelphia.
Musical Red.
No, it's not positive. but-
Yeah, it's not positive.
There's a nurse or PA on ER who's incidentally positive. That's not her. You know, everybody seems to know it, and it's not her.
Maybe not all seriously.
I only watched it because I went Clooney and Carter to have a romance that didn't happen. So.
But things like the movie Philadelphia, binge watch Mike Nichols' Angels in America sometime on Max.
HBO Max?
Yeah, HBO Max. That's incredible. The stories of, and you can find any number of movies streaming about the early years of the epidemic. And that can be very educational to remember what people went through.
All right, panelists, are there any final thoughts? Audience, any final questions?
So having lived in Minneapolis and St. Louis and then moving to Holland, Michigan, there is nothing to sit here in Ottawa County and even less in the last 2 years. So I would vote.
Thank you.
I'm going to turn things over briefly to David, who has a poem to share.
I brought this because it is written by a man who's a performance artist whose partner died from AIDS. And it is in honoring all the patients who I lost, the process that I watched them go through, wasting, becoming old men in their 20s and 30s. Because I think it brings that reality home, and I think we need to know how to what to balance that here. When I put my hands on your body, on your flesh, I feel the history of that body, not just the beginning of its forming in a distant life, but all the way beyond its ending. I feel the warmth, the texture, and simultaneously I see the flesh unwrapped from the layers of fat and disappear. I see the fat disappear from the muscle. I see the muscle disappearing from around the organs and detaching itself from the bones. I see the organs gradually fade into transparency, leaving a gleaming skeleton, gleaming like ivory that slowly resolves until it becomes dust. I am consumed in the sense of your weight, the way your flesh occupies momentary space, the fullness of it beneath my palms. I am amazed at how perfectly my body fits to the curves. Your body fits to the curves of my hands. If I could attach our blood vessels so we could become each other, I would. If I could attach our blood vessels in order to anchor you to the earth, to this present time, I would. If I could open up your body and slip inside your skin and look out your eyes and forever have my lips fused with yours, I would. It makes me weep to feel the history of your flesh beneath my hands in the time of so much loss. It makes me weep to feel the movement of your flesh beneath my palms as you twist and turn over to one side to create a series of gestures to reach up around my neck, to draw me nearer. All these memories will be lost in time like tears in the rain. Thank you for helping us honor those things.
Thank you so much to our panelists for sharing with so much transparency and authenticity and using your voices to continue to advocate and speak truth to what your experiences have been and the experiences of the people that you've loved. Thank you to our audience for being here and wanting to educate yourself, wanting to know, wanting to hear these experiences. I'm going to go ahead and turn this over to Bethany, who's going to close us out. Panelists, please give them a big round of applause.
So I want to thank again Holland Museum out in the Lakeshore Doug has some awesome show and tell over here, so please come check out Doug's show and tell. He's got lots of artifacts and memorabilia here about his memories of all kinds of things related to what we've been discussing here tonight. So I just want to let you know, we have the Reg Projects table back here that you can visit and see, talk to them and see what kinds of things they have to share with you over there. We also have out on the Lakeshore's table here. Everything on that table is free, so please help yourself. There's lots of little freebies and stuff. There's also information about the last 3 events that we have for our Holland Pride in the month of June. This was the 4th to last. So next one is our last speaker series. It's an advocacy workshop next Monday, a week from today. And then on the 29th, we have both our Holland Pride Festival and a drag show. Helping support the work, all proceeds go to Out on the Lakeshore. I am selling raffle tickets tonight. I can take cash or credit, so you can meet me over there if you're interested in that. We're drawing winners at the drag show, but you don't have to be there to win. So, Sarah, am I forgetting anything? No? All right, thank you so much for being here. Everybody have a great night.